Welcome to the first educational session of the PQA annual meeting. We are going to be doing Tackling Social Determinants of Health by leveraging community pharmacies in a national scalable model. This program does have CE, brought to you by ProCE. If you'd like to receive your continuing education credit, please complete the online post-test and evaluation by July 10th. For those of you joining us live, the attendance code for this session will be provided at the end of the presentation. For those taking this program as an on-demand content, we will be providing that in another format. If you have any questions, please refer to the continuing education section of the PQA annual meeting microsite. I'm excited to introduce our presenters today. First, we have Dani Markus joining us from OutcomesMTM, and with her is going to be Sarah Dean, who's joining us from Humana. They have a variety of learning objectives that they'll be teaching us about in the course of their presentation. Sarah?
Thanks, Jake. So our agenda for today is to discuss some background that led to this project, to overview the social determinant of health service, and then lastly to discuss the pilot results and the lessons learned. And to begin, many of you will recognize that social determinants of health has become a prominent buzzword in the healthcare industry over the past few years. And we know the conditions in which people live, learn, work, and play can affect their health risks and outcomes. So recognizing the impact of social determinants of health and the need to further explore their prevalence in our population, Humana worked with OutcomesMTM to design a study that would do the following. First, to test the social determinant of health screening and collect member responses. Second, to understand if retail pharmacists could successfully intervene regarding social determinants. And lastly, to understand if adherence gap closure could occur based on these interventions.
So next we'll go into the service development background. So this is actually what, I'll go into detail about what was actually completed as far as the assessment between the pharmacists and the patients. So the goal when we were developing this service was to make sure that we capture this valuable information for our payers or our clients. The second was to provide health plan specific resources so the network would be able to take action based on the results of the assessment. We were able to, during this pilot, embed a health plan tool. So Humana actually has a tool where you can go and search by zip code to find local resources available to address some of these social determinants of health issues. And then lastly, we wanted to design it in a way that could be reused and have consistency for a scalable network delivery by basically a nation of pharmacists, which was done in this pilot. So the result of that is a 9-question survey that was embedded into the documentation. And these questions were adapted from the AHC screening tool from CMS and the Prepare tool from the National Association of Community Health Centers. So it wasn't an exact replica of either of those questionnaires, but adapted, an adapted version with those used as resources. So the result was an assessment that had various social determinants of health domains with specific questions. The domains included housing, food, transportation, physical and emotional needs, and school and work. So next I will go into the detailed questions. So the first couple were related to housing. So the first was, what is your housing situation today? The second was, are you worried about losing your housing? The next domain was related to food. So we asked, within the past 12 months, you worried that your food would run out before you got money to buy more. And the second was, within the past 12 months, the food you bought just didn't last and you didn't have money to get more. So difference between that is that they worried the food was going to run out, and the second was that they actually experienced that the food did not last. Next, we had transportation. So we asked, in the past 12 months, has lack of reliable transportation kept you from medical appointments, meetings, work, or from getting things needed for daily living? The next domain was physical and emotional needs. How often do you feel lonely or isolated from those around you? And do you feel physically and emotionally safe where you currently live? And the last domain was related to school and work. So the first question here was, do you want help finding or keeping work or a job? And the second was, do you want help with school or training? For example, starting or completing job training or getting a high school diploma, GED, or equivalent. So this is an actual screenshot from the system that shows what the documentation requirements look like, and then you can get a little insight into the answers to the first couple questions at least.
And our study took place in the fourth quarter of 2019, and when designing our study, we looked at the following population. So members needed to be enrolled in a Humana Medicare Advantage contract and also be non-adherent to a chronic condition medication for at least one of the 7 conditions that you see here in the middle of this slide. And then to be included in the final outcomes, members needed to be enrolled and still have that chronic condition at 2 months post the study period.
Okay, so next we have high-level TIP performance metrics. So our TMR program is, we refer to it as the Targeted Intervention Program, so that's what TIP stands for. And basically, each TIP is one MTM opportunity that was deployed or published out to the network for completion of this social determinants of health assessment. So the first row here shows you the volume of opportunities that we did publish during the pilot program. Of note, the services were only available for 6 weeks. So they launched on November 15 and the program ended on 12/31. So keep in mind the time of year that this pilot was running. It was the end of the year over the holiday season. Things in the pharmacy are busy, and in the MTM world, there's a lot of activity related to final adherence pushes and CMRs, getting those done before the end of the calendar year. So in total, we had just shy of 124,000 opportunities that were available to pharmacies. Those published at a total of 16,000 pharmacies. So that gives you a good sense of the scale and the size of this pilot. So of those 124,000 opportunities, we had just over 17,000 completed, which results in a 14% completion rate. Almost 3,500 pharmacies participated in the completion of these assessments. Of those that were completed, we had 9,800 successfully completed social determinants of health assessments, which yields a 56% success rate. And over 2,000 pharmacies successfully completed at least one social determinants of health assessment with a member. And then the last 3 rows show you the unsuccessful results. So the users, the pharmacists and technicians can mark these with unsuccessful results. So maybe the patient refused the service, the pharmacist was unable to reach the patient, or they deemed that there was no intervention needed for this individual patient. So you can see those rates following, as well as the number of pharmacies that submitted at least one claim with that unsuccessful result.
All right, so diving a little bit more into the metrics reported from the social determinant of health screenings, of the 9,800 successful interventions, we found that food insecurity, social isolation, and transportation were the most frequently reported social determinants of health by our population. 12.5% reported that food did not last and there was no money to get more in the past 12 months. 11.2% reported a lack of transportation in the last 12 months, and then 18% reported feeling sometimes, often, or always lonely or socially isolated. And that breaks down further to 4% reporting feeling always or often socially isolated. And similarly, the food insecurity and loneliness were the most commonly reported metrics in the free text responses. We had 43% report that food insecurity was a concern in the free text, and 31% report a free text response related to social isolation or loneliness. So next I will share our findings from when looking at the results by chronic condition type, we found that members with COPD and depression had a higher rate of social determinants of health compared to the total population. So you can see the results in this table show the reported rates for the average population, as well as those broken out by members with COPD and depression. And the bolded numbers highlight those rates that are above what the average presented. So I will call it specifically, depression presented 3% higher rate of running out of food and a 5% higher rate of feeling lonely or socially isolated. And members with COPD did have a similar trend, but those with depression had the highest rate of any chronic condition. And no condition demonstrated consistently lower rates across the determinants compared to the average population. The results for housing, work and education, and physical and emotional safety were reported consistently across all conditions. So now I will share our findings from a follow-up analysis that we completed of the screen population. And I'll note that these results compare members who successfully had a screening completed versus those that did not have a screening completed. So as I mentioned earlier, this population was examined in the 10 months pre and 2 months post-intervention period, so from March of 2019 to the end of February of 2020. And ideally, we would look at outcomes from 6 months post the intervention and compare that data to 6 months prior to the intervention. But the data that we have today is early indicator findings that we have available at this point in time. And further, we also have some concerns that as we look more into 2020, our results may be skewed by the impacts of COVID-19 and additional social determinants that members may have or behaviors that they may have adopted that would not have previously been presented. Overall, however, we did find completion of a screening demonstrated a variable impact on medication adherence, and 2 chronic conditions had statistically significant positive lift in medication adherence. 2 conditions had a negative decline that was statistically significant for medication adherence, and 3 conditions had no statistical impact. So it is important to note that these results capture a single point in time, so they are expected to change over time as members adopt behaviors, either positive or negative, that may impact their adherence. So here you can see a breakout of those results at 2 months post the study period. And for members who completed a screening with COPD, depression, or osteoporosis, they demonstrated a positive lift in their medication adherence. And this is statistically significant for members with COPD with a 6.6% lift in medication adherence rates, and statistically significant for those with depression with a 5% lift in adherence. Members with atrial fibrillation, diabetes, hypertension, and hyperlipidemia all demonstrated a negative decline in medication adherence rates, with statistical significance shown for hypertension and hyperlipidemia. But again, I will note that this is just a point in time, and so we did see some variables in these responses at the 3-month mark compared to the 2-month mark. And then lastly, we examined the impact of the screening on total medical and pharmacy spend. And again, this is looking at the 2 months post the study with a full 12-month aggregate data from the year prior. So the results may change as members move further away from that intervention time period. Overall, though, we did see favorable impact from the service. Members who completed a screening did demonstrate statistically significant reduction in medical spend and an insignificant increase in pharmacy spend. And with these results, it's important to remember that improved adherence will always or often result in higher pharmacy costs. And so this is the trend that we actually do want to see. And while the pharmacy cost isn't significant, the pattern does show the right pathway. So overall, our reduction in medical spend was on average $1,500 per member, and the increase in pharmacy spend was an average of $500 per member in the year period. And I'll note we did see a reduced medical spend to be the highest and the increased pharmacy spend to be the lowest at the 2 months post-intervention compared to the 3 months post-intervention time period. So this is to say that the results may be less impactful over time, but again, we would need to further qualify that to determine if it's accurate.
Okay, so now we'll review the qualitative results. So one thing to keep in mind is that this assessment, really the intent of it, the primary intent of it was to gather the information. We do expect that if the members or patients indicated they did have a challenge or kind of tested positive on one of these assessment questions, it was likely that the pharmacist or technician would offer resources, but that was not necessarily a requirement of the service. And I'll talk a little bit more about that later in some next steps. But initial learnings is it is very beneficial to provide those resources to the network. So when I say client-specific resources, I mean health plan-specific. So we were able to embed, as I mentioned earlier, the Humana tool that allows you to search by zip code to find local resources. And that really arms the pharmacist to provide solutions and not just gather this sensitive information that can really uncover some challenges for the patient and not be able to offer a solution. So that's really important. The next is to align on how the health plan is going to close the loop with the patient. So that's important for the pharmacist to be able to communicate with the member and be on the same page regarding expectations on how things are being answered, and for the pharmacist to be able to say with some level of confidence if the patient should expect follow-up from their health plan or maybe not. So as far as network feedback goes, we were able to offer some best practices to initiate and guide conversation. I think we've learned a lot through just this initial pilot period. One of the best things I would say that we've learned is it's more successful when you try to pair this assessment with another MTM service. Since this is a non-medication related topic, it can be maybe a little jarring for the patient to just be asked these questions out of the blue if it's not accompanied by another conversation. So that's definitely a best practice that we have heard and learned through this pilot program. The second is, this isn't really surprising, but we did see a variation in patient response. So on one end of the spectrum, some patients really did not want to engage in this conversation, and in some cases were almost offended. They were being asked questions like this. One example I recall seeing is the patient was actually a retired doctor and didn't have any of these problems and was confused why they were being asked these questions. And then I'll show you on the other end of the spectrum some success stories where some people really did have some issues and the pharmacists were able to help connect them to local resources. And probably the most significant piece of feedback that we got through this pilot from the network is around evaluating the legal liability related to the question, do you feel physically and emotionally safe where you live? So if the patient responds no, what is the pharmacist's liability, potential liability, now that they've discovered that information? Do they need to take any action based upon that? So that's something we are needing to evaluate. A couple of success stories. And again, I'll just emphasize again, the primary intent of the service as it was designed for the pilot was to gather the information. That there was a tool available to connect patients with resources, but you'll kind of see the variation in how the services were deployed with these two stories. So the first is, this is free text notes that came in with the claim. It said patient is struggling to afford food. He says he is not currently on food stamps, and getting him in touch with the appropriate agency to help him with this would be beneficial. So that was the pharmacist kind of expecting that someone else was going to help get this patient in touch with an appropriate agency. And then on the other side of it, we have where the pharmacist actually did that connecting themselves. So this one says, we also educated the patient on the available local sources of social assistance, such as the Red Cross, Salvation Army, Haven of Mercy, etc. We flagged the patient's chart to follow up with her when she comes to the pharmacy. So you can kind of see the variation in responses when there was an issue discovered as a result of doing this assessment. All right, so next steps, probably the main limitation on some of the results that Sarah showed is the relatively short study period. So it was 6 weeks long. That being said, we did have a high volume of services that were published, and at the end of the day, we had 9,800 successfully completed social determinants of health assessments. So that's really great to see. The follow-up timeframe, since we just ended the pilot at the end of 2019, that run-out period to do that assessment is relatively short. And like Sarah mentioned, we aren't sure what this COVID-19 world and the impact that has on fill patterns and medical utilization, things of that nature. So as far as next steps, what we're doing is we're considering assessment revisions such as removing or revising the question regarding physical and emotional safety, given the potential legal liability of discovering that information and what the pharmacist should be doing if they do find that a patient does not feel physically or emotionally safe. And another thing we're looking at is adjusting the work and training domain questions based on patient demographics. So this particular pilot was run with Medicare members. So there were responses, positive responses to these domain questions were very, very low. Makes sense given those patient demographics, but I would expect that might be a greater concern in maybe a Medicaid or commercial population. And then something else we're looking at is a follow-up service to foster a more action-oriented conversation to connect patients directly with resources. So this could look like a follow-up service. Maybe we need to tweak the assessment to drive that conversation more immediately. But I think we all recognize that capturing the data is one thing, but doing something and trying to connect patients with the resources that they need is more likely to be impactful for that individual.
All right, and in conclusion, we learned that pharmacists can be leveraged to address social determinants of health with patients, and these screenings can have favorable impacts on medical and pharmacy spend as well as medication adherence. However, we know now that the impacts can vary quite a bit by chronic condition type as well as point in time of analysis. So future studies should examine the appropriate time for screening as well as follow-up and assess the findings at multiple time periods after the intervention. And then lastly, also engage the optimal population by condition type. And that concludes our presentation. With that, what questions can we answer?